Hello, and welcome to the Legacy Education ICD-10-CM Guideline Review Series. I am Tiffany Roach, the Coding Coach, and I will be walking you through the ICD-10-CM guidelines. This video will cover the general coding guidelines for ICD-10-CM. This presentation is designed to review the ICD-10-CM guidelines that are effective for both fiscal year 2024 and 2025. There were no changes to the guidelines from fiscal year 2024 to 2025. The general coding guidelines begin with locating a code within the ICD-10-CM. First, you will want to locate your main term in the alphabetic index, and as always, you want to verify that code within the tabular list. While in the tabular list, you should always look at the instructional notes, as well as your includes and excludes notes. Paying attention to the level of detail on your code is important. Diagnosis codes should always be reported at the highest number of characters available and to the highest level of specificity that is documented within the medical record. Codes can range from 3 characters to 7 characters. A 3-character code should only be used if no further subdivision is available. If it has not been coded to the fullest number of characters available, it will be considered an invalid code. Each encounter requires a valid diagnosis code. You should never code an encounter without a reason for that encounter. When signs and symptoms are documented and there is a definitive diagnosis associated with those signs and symptoms, only the definitive diagnosis should be coded. For example, if a patient comes in with a fever, nausea and vomiting, and body aches, and the provider diagnoses the patient with the flu, you should only code for the flu because the symptoms are routinely associated with that condition. If there is no definitive diagnosis documented that is associated with signs and symptoms, then you can also code those signs and symptoms. For example, if the patient has diabetes and also presents with a cough, you are able to code both the diabetes and the cough, as your cough is not routinely associated with diabetes. Sometimes conditions require multiple codes to fully describe said condition. When that happens, a use additional note will be found in the tabular list. In this case, a secondary code is needed to represent the complete condition. An example of this would be for bacterial infections. If a code is needed from other than Chapter 1, a second code from Category B95 or B96 may be required to identify the bacterial organism that has caused the infection. Code first, or code if applicable, any causal condition first notes may be found in the tabular to indicate that an additional code should be sequenced first. Also, when coding for sequela or late effects, complications, and pregnancy, it is sometimes necessary to have a second code to fully describe a condition. Make sure to check the chapter-specific guidelines for further instructions. Sometimes documentation will support acute and chronic versions of the same condition. If separate entries exist within the alphabetic index at the same indentation level, both should be coded with an acute sequenced first. Combination codes are going to be those that are a single code that describe one of the following. You can either have 2 diagnoses, a condition with an associated manifestation, or a diagnosis with an associated complication. Your combination codes can be found in the alphabetic index by referring to the subterm entry under a condition. When a combination code exists that fully describes the diagnosis, multiple codes should not be used. Only when the combination code lacks specificity should an additional code be used. Sequelas, also known as late effects or residual effects, are conditions that are produced after the acute phase of an illness or injury has resolved. The sequela can appear early, or it can appear months or years later. There is no time limit on when a sequela can be used. Typically, the coding of a sequela will require 2 codes with the condition or the nature of the sequela sequenced first, followed by the sequela itself. Some examples of sequelas are scar formation that results from a burn that has healed, a deviated septum due to a nasal fracture, and infertility due to tubal occlusion from old tuberculosis. There is an exception, however. Sometimes the codes for the sequela is followed by a manifestation code that's identified in the tabular list, or the sequela may be needed to expand to include the manifestation. It's also important to note that the acute phase of an illness or injury should never be coded with a late effect code. For professional coding, conditions described as impending or threatened should be coded as follows. If it is confirmed and it did occur, it can be coded as a confirmed diagnosis. If it did not occur, it should only be coded if the alphabetic index has an entry for impending or threatened. If impending or threatened is not listed, only the existing underlying condition should be assigned. Each diagnosis code should be reported once for an encounter, no exceptions. Some ICD-10-CM codes will specify whether the condition occurs on the left, right, or bilateral. If only left or right codes are provided and the condition is bilateral, you should assign 2 codes, one for the left and one for the right. If your laterality is not specified within the documentation, the code for an unspecified side should be assigned. If the patient has a bilateral condition and only one side is treated during an encounter, a bilateral code should still be assigned. For the next encounter, if the treatment for the one side has been completed and the condition no longer exists bilaterally, only the unilateral code should be assigned. For example, if the patient has cataracts bilaterally and they are treated during separate sessions, the first session would have a bilateral code. After the treatment on the one side, for this example, we'll say the left, the cataract is now only present on the right side. The second encounter should only have a code for the right side. When your laterality is not documented by the provider, the code assignment for laterality can be based on documentation from other clinicians. If there is conflicting documentation, at that point the provider should be queried. An unspecified laterality code should rarely be used and should only be used when it is not possible to obtain clarification from your provider. Majority of the time, the code assignment should be based solely on the documentation by the provider. However, there are some exceptions. When coding for any of the conditions that are listed here, as long as the condition is documented by the provider, additional details can be derived from the clinician's documentation. For example, if the provider documents obesity or morbid obesity, the BMI can be coded from the vitals that are recorded by the clinician. Also, if the provider documents that an ulcer is present on the leg, the stage of that pressure ulcer can be coded from the clinical documentation. The codes used for additional information should always be reported as your secondary diagnosis, and the condition reported by the provider should be your first listed. When syndromes are documented and the alphabetic index does not have guidance, you should assign the documented manifestations of that syndrome. If there are manifestations that are not a part of the disease, you can code those as well. Complications of care should only be coded when there is a documented cause and effect relationship between the care and the condition, as well as the documentation that the condition is clinically significant. The term complication does not have to be used within the record. So, for example, if the condition alters the course of the surgery as documented within the operative report, it would be appropriate to report that as a complication code. If the provider documents a borderline diagnosis at the time of discharge, check the alphabetic index for a borderline entry. If no entry exists, then you can code it as a confirmed condition. While it's important to code to the highest specificity, there will be times where a sign, symptom, or unspecified code should be used. If the medical record documentation supports such type of code, you can use those. Make sure to review the entire record to determine the reason for the encounter and the conditions. If a definitive diagnosis has not been established by the end of the encounter, you may assign a code for the sign or symptom. Unspecified codes should only be reported when there are codes that most accurately reflect what is known about the patient at the time of the encounter. When coding for encounters in hurricane aftermath, an external cause of morbidity code should be assigned. These external cause codes should never be reported as a primary or first listed diagnosis, as the reason for the encounter should be sequenced before any external cause codes. These codes can represent the cause of the injury, the intent, the place where it occurred, the activity of the patient at the time of the event, and the person's status. They should not be used when there is no injury that has occurred. Codes for cataclysmic events should take sequencing priority over all external cause codes, except for child abuse and adult abuse or terrorism. You should assign as many external cause codes as necessary to fully explain each event. If a patient presents with an injury that is not a direct result of the hurricane, you should not assign X37.0 for hurricane. For an example, if an evacuee has incurred an injury as a result of an MVA, you should assign the code for the MVA only. If it is unclear whether the injury is a result of the hurricane, then it is safe to assume that the injury is due to the hurricane and it can be coded as such. Z codes can be assigned, when appropriate, to further explain the reason that the patient is presenting for health care. Make sure to review the guidelines for reporting your Z codes to determine your sequencing. Listed here are a few possible examples of Z codes. We will go further into Z codes when we review Chapter 21. The codes that are listed in this guideline on the previous slide are not an all-inclusive list, and you should always consult your alphabetic index and tabular list. You should assign as many codes as necessary to fully explain the encounter. As always, thank you for supporting us, and make sure to stay tuned for new videos in our ICD-10-CM guideline review. Also, make sure to subscribe to our channel so that you can be in the know of our newest videos that are released.